You okay? You expect me to laugh at it?
I
Uh,
am.
uh,
I'm so excited about the topic today, guys. My 8-year-old has a joke that's all about eyes, and so I
wow.
really want to tell it. So, Dr. B, are you ready for it?
Well, let's hear it. A joke
Okay.
from you here is always exciting.
What did the left eye tell the right eye?
So, guys, by the way, when you're joining in, please mention your name, where you are coming from, and what your guess would be on this one. I want
Yeah,
to see the audience answer.
I
My
want
answer
to see the
is
audience's answer too, so we can hold off just a little bit. What did the left eye tell the right eye?
okay. So here's my answer. How come you're always right? All I could make up. Well, by the way, as people are joining, I would say that this conversation is recorded if you're hearing it later. And if you have questions or comment, please definitely ask those to us. It's kind of a cool and exciting topic today. All right, Jamie, what else is happening? Or give
Not
your answer. Hey, why don't you give your
okay.
answer?
My answer. The left eye told the right answer. Something smells between us.
Gotcha. All right. Got it. Got it. Here's
Little bit of
Eugene
kid
from
humor.
Norwalk. Hello, Eugene.
Welcome. So, Dr. Bhargava, just for our audience, is there any sort of studies that we're recruiting for that some of these guys might be interested in looking at or hearing about?
Yeah. So the one study that I thought would be worth talking about is pertains to being able. There's a lot of sensors on the market, and we have talked about that. There's a study with Dexcom sensor, which they can get the sensor for about 8 months. You have to have diabetes, A1C 7.5 or more, and be on insulin and above age 65. So this is a great way for people to actually get a sensor that's already on the market, of course, free of cost. And there's some travel stipend as well. So if people are interested, they can go to iowadiabetes.com or call the number 329-5690. So that's the study in focus.
Now we're getting lots of people joining us. Casey from Beaverdale, Morgan from West Des Moines, Vicky, welcome back from Waterloo, Carla from Altoona, and Brad from North Liberty. So everybody representing from all over. And we've got Holly, welcome, and Suba, thanks for coming back.
Excellent. All right, I guess it's time to get started. Well, great topic today. Thank you, everyone, for joining. And uh, here's the thing, diabetes is the leading cause of many things. In the context of today, diabetes is the leading cause of new cases of blindness in adults in US. Still to date, it's the leading number one cause. The diabetes eye changes affect almost one third of adults over age 40 with diabetes. So thank you for joining. Quickly, I'm Dr. B, Dr. Bhargava. I've been doing this stuff or diabetes for last 25 years, anything, everything I can against diabetes. And I'm excited that you all have joined in our quest to change diabetes together. Today is kind of cool. We have a guest speaker with us, and of course, my partner in crime, Jamie. So, Dr. Jamie Pitlick, pharmacist, very passionate about diabetes. She's joining us, and Dr. Ethan Heisman from Elite Eye Care is joining us as well. And here's kind of the three things we'll talk about today. What are the different types of eye complications associated with diabetes? One, how to prevent these from occurring too. And then what to do if you have symptoms of eye disease. These are the three things we will answer today. So, Jamie, welcome. Ethan, welcome.
Thank you.
Thank you for having me.
Great.
So, as we're getting started, just a few reminders. Thanks to you guys for joining us. The more active you are on Facebook, the bigger a community that we can build and we can start changing diabetes together. So just as a reminder, we're always looking to see what you guys are doing on Facebook. And we've got that community building award that we will give away every month. Last month, we gave away a cookbook. That was an amazing gift, a autographed cookbook with Chef Robert Lewis. Also, we've got a lot of content, something that we haven't told you about. We've got a lot of videos on YouTube and actually have an Eye-owa Diabetes YouTube channel. So you can always go to that, subscribe so that you know when we're putting information out there. a lot of the frequently asked questions we're trying to put out there as well. So it's there, and we've given you the link to it. Let's get us started by doing a quick poll. So the first poll for you guys is, which of the following is associated with uncontrolled diabetes? And you can just, in your chat, let us know by putting A, B, C, D, E, F, or G. This goes beyond just the A, B, C, D that I normally test on.
I don't have diabetes, but I need new glasses.
We can help you out.
Oh, yes. Right there. There we go. Yes.
Perfect.
Molly says F, which is everything. Oh.
There we go.
F. Jean F. Roxanne F. You guys are copying from each other. Press it. Come on. That's easy. Come on. And you're right. So.
Yeah. And so, yeah, you guys are definitely right. Uncontrolled, and the way I worded it is important. Uncontrolled diabetes is associated with all of the above. And thankfully, we have an expert here to talk to you guys about that. So, Ethan, if you want to kind of talk through some of the more common things that you see and walk us through what patients can look for.
Absolutely. So the first that kind of flies under the radar sometimes is when your diabetes is out of control, it can actually change your glasses prescription. So you get changes inside the eye that cause that. So sometimes what will happen is patients will come to us and they say, boy, I feel like my vision has changed so much over the last 2 months, 3 months, 6 months. And we see a huge shift in their prescription. And the first thing that comes to mind for us is that patient diabetic? So that's always the first question we ask is, how recently have you had a physical? Have you had your blood glucose checked? And we will have them have that tested before we change the glasses prescription to see, because when you're an adult, it's not normal to have the prescription changed that much that quickly. All the rest of the complications are associated with the eye complications, not all of them, but most common are, one of the side effects of diabetes is it can cause the blood vessels anywhere in our body to start to leak. And when those blood vessels leak, you start to get blood going where it shouldn't. And that's why, similar, you have complications with blood pooling in your lower extremities, the feet and toes and things like that. When that happens inside the eye and you get that blood leaking outside the blood vessels inside the eye, that's what causes the damage. And that's what causes, in some unfortunate cases, the blindness from diabetes. So if you think of your eye like an old film camera, I know people younger than me are like, what's a film camera? But if you think of the eye like an old film camera, the retina, which is the inside lining of the eye, that's the film. And it has blood vessels all through that layer in the retina. And when the blood leaks in the retina, that causes swelling and will cause the vision to start to seem blurry, out of focus, and things like that. And if that's not addressed really quickly, then you can start to get the cascade where you get scarring, you get more swelling, and that's what can cause, unfortunately, the permanent vision loss. A couple of the other potential side effects from diabetes with the eye is it can cause cataract formation sooner. So a cataract is what we have, a lens that sits right behind our pupil. And a cataract is when that gets cloudy. And then it's kind of like you're looking through a dirty window and you're not seeing as clearly. So cataracts are very normal as we age, but diabetes can cause that to happen even quicker. And so with those, with the cataract, kind of seems like everything kind of starts to get a little cloudy. Lights start to get more glare. Light starts to get more halos. And you're just not seeing as well when you have that. And then the final thing is glaucoma. Glaucoma is a disease of the optic nerve, which connects your eye back to the brain. And if it's not treated, that nerve can essentially slowly die, but it is very treatable. But with patients with glaucoma, the incidence of, or patients with diabetes, the incidence of glaucoma definitely increases as time goes along. And it's just like everything else. If the diabetes is uncontrolled, that's where the highest risk is.
So there are some questions coming out here. And there's one from Jean. It says, is it normal for some bleeding as you age? And I'm assuming Jean is saying in the eyes.
That's a great question. There are a lot of studies that have shown, even if you have great control of your diabetes, that after 15 years, you can start to get really small changes. Now, these are small changes that will not affect your vision at all. And they don't have the real high risk of losing your vision or blindness. But you are correct, Gene. There is a lot of evidence that once you've had even controlled diabetes, you can start to get those small changes that don't affect the vision.
Now, I have to say something against that, which I say all the time. Diabetes is a leading cause of many things, but controlled diabetes is the cause of nothing. Meaning, what I'm trying to say, even that bleeding that you're talking probably has no meaningful impact on that patient or those patients. So just from a messaging standpoint, I like to tell people also that when your diabetes is controlled, it's a cause of none of these complications. It's good to know that some things will happen, but probably they're not either meaningful to you, me, or the patient.
Absolutely. That's spot on.
We had a couple of audience members submit pre-questions, and so I think this is a great spot to do it. So we had somebody ask, how does diabetes affect wet macular degeneration?
That's a great question. Macular degeneration is also a disease of the retina, the inside lining of our eye, where the cells in that area get disrupted over time. So there's dry macular degeneration, which you get maybe a little bit of blurred vision, maybe a little distortion in your central vision. And then there's wet macular degeneration. And what happens with wet macular degeneration is you actually do get bleeding in the retina inside the eye, and it can cause very rapid, very severe vision loss. It's similar in the diabetic eye disease in that you get the blood vessels where they should not be in the retina. And that's the same thing that the uncontrolled diabetes will do. So they both do the same thing, but kind of differently. Now, if you have uncontrolled diabetes and you have wet macular degeneration, that's a really difficult combination, and it will definitely increase the risk of vision loss. So obviously the diabetic control is important, but if you have somebody who already has wet macular degeneration, that even makes it that much more important to have good control.
So I know you were talking about all the different parts of the eyes, and we've got some great pictures that you and Dr. Bhargava supplied for us. So I don't know if you want to talk briefly through on these slides what you're seeing and how you would teach our patients about them.
Absolutely. So this is a picture of a healthy, no problems retina. And so kind of think where we're looking. This is like we're looking in through your pupil into the back of the eye. So we're looking through the front of the camera all the way back to the film. And the little yellow circle you see there, that's the optic nerve. That's what connects the eye back to the brain. And the darker area over to the right, that's the macula. And that's the part of the retina we use for our straight ahead vision. So that's very sensitive. There's a lot more light receptors there, and that's why our central vision is sharper. And then you can see all the blood vessels cascading around there. There's more blood vessels in the central part of the eye because there's so many more photoreceptors there. So there's a lot higher risk if there's going to be a diabetic change, it's going to be right there in the middle. So that's a great example of a healthy retina.
And that's what we want for all of you, right? So
absolutely. Now this, you start to see the example of an unhealthy retina that has diabetic eye changes. So where you see the red splotchy, that's where there's blood that's actually leaked out of the blood vessels in the retina and started to cause disruption. And you see some kind of the whitish fluffy lesion, that's almost like a cholesterol-like material that comes out of the blood vessels also and can cause those changes. So this is what we would consider a severe case of diabetic eye change. This has been going on for quite a bit and has really caused a lot of damage. But the thing about that middle picture, that patient still might have 20/20 vision. That's why we don't rely on our patient symptoms all the time to figure out, do we need to get our eyes checked? Do we not need to get our eyes checked? Because you could have that much damage and not have any symptoms at all from the patient, which is kind of the scary thing about it. Now on the right, this is a very, very advanced case of diabetic eye disease. And there's been a lot that's gone on to the point that the retina, there's actually been a retinal detachment. This is very, very, very severe. And this is definitely what we work every day in our clinics to prevent, having this much damage, because this is really going to affect someone's quality of life if it gets to this point.
I want to pause here for a second. Maybe you want to talk about the last photograph, and then there's a bunch of audience questions and comments that I want to talk about. But go ahead.
No, you go ahead. Let's take the questions.
All right. So going back, people were also describing somebody had cataract, somebody had choice A. Question wise, are floaters a sign of something from Casey?
That's a great question. Floaters can be normal. If you have kind of a single or isolated floater and it's always about the same size and it's always about the same shape and there's no other symptoms, that can be very normal. And you notice it especially if you're looking at a bright background, if it's a bright sunny day or if it's a light colored wall with bright lights and you kind of see that same, it's kind of squiggly, that can be very normal. What we worry about is if you get a big change in floaters. So instead of just one, all of a sudden you see kind of a waterfall or a cascade of floaters that's pretty startling and alarming. That can be very concerning. The other thing is if you start to see new floaters and if there are flashes of light out in the side of your vision, almost like lightning strikes, that's very, very concerning. And that's one of the things that if you ever experience that, you should make sure that you get your eyes checked as soon as possible.
Well, thank you. This is extremely helpful, meaningful information for our audience. The next question from Michelle. She says, what do you consider controlled diabetes? A1C below 7, question mark, question mark. I'll take that. And yes, that is the American Diabetes Association target. Everything is going towards personalization, Michelle. So the key thing I say is it's somewhere between 6.5 and 7 based on a few key parameters. People who are younger, who don't take medicine that cause hypoglycemia and don't have heart disease, we shoot for 6.5. Everybody else, we shoot for 7. As you get older, if you're in 70s and 80s, we may relax to 7.5 and so. All right, I have a personal comment from Carla for Dr. Heisman. This gets personal. Dr. Heisman, the picture behind you reminds me of eye floaters. Did you read that, by the way? Do people with diabetes get more floaters than normal?
There is a slight tendency, and this is one of those things that this is not steeped in scientific literature, but there are some changes that are associated with diabetes and the effect on the eye that they can experience more floaters. And I'm glad you noticed this because we saw this painting at an art festival years ago, and it reminded me of floaters, which is why I was attracted to it. So I appreciate that, Carla.
Very cool. All right. Randy has mentioned he has bleeders right now being treated. And Randy, all the best for that. This is the complication we definitely want to avoid. Good control does matter, when you have diabetes, even in the advanced stages. So definitely good diabetes control will help. Another question from Jean. Will you see gradual breakdown even with well-controlled diabetes after many years?
You might. That's a great question. And you might. And like I said, there are some studies that have shown that, but I've definitely seen well-controlled patients with diabetes who they've had diagnosis for 25 or 30 years with no eye changes. So it's not always, you don't always get those changes. And like Dr. Bhargava said, well-controlled diabetes isn't the cause of anything. And so if you have had really good consistency, you can go decades without any changes.
So let me tell you one story about eye disease and diabetes. In India, it's very hard to get screened for diabetes, and people are afraid of getting blood tests and so forth, and it's just not very practical. So interesting thing you might find, they started looking at their eyes, and when they started doing the retina exams, that's how they started diagnosing diabetes in the rural India. And that's really a horribly wrong way of diagnosing diabetes, but they have no other mechanism. In US, I've seen patients who at the time of diagnosis have retinopathy. And that's, again, a problem. We do not want to get there. So good control and getting your eye exams done early, these are some things I want to emphasize.
I see one question from Connie. I'm going to pause before we do that. I want to go and actually show you guys. Dr. Heisman had some great pictures of actually visualizations of what patients might actually see. And so if you want to describe what we're seeing right here in this picture.
Absolutely. So what we're seeing here is when you have the diabetic retinopathy or the diabetic eye disease and you start to get the blood vessels leaking and you get the swelling in the retina, it tends to happen right in the center of your vision. And then when that happens, like I said, it's like messing up the film of the camera. And so you can see right in the center of the vision there's a big disturbance and a big blur, but then out in the periphery, it's kind of clear. So that's different than just my glasses changed. It's blurrier in the center and clearer around the outside because of how that swelling happens. And you can see there are some increase in the floaters in this simulation also.
Okay.
And then sometimes, I think we have the night picture also, and sometimes it's even more pronounced at nighttime. And with this could be from the diabetic eye changes, and this can also be from a cataract formation where you start to see more glare and you start to see more halos around lights. So either way, that's something that you want to make sure if you start to experience that change that you get that evaluated as soon as possible.
I think these are very telling pictures, so I'm glad you were able to bring them to us, things that you guys can look out for and watch for. So now kind of going back to some of the questions, Connie's asking, do you have any suggestions for light sensitivity?
Ooh, that's a great question, Connie. If it's not anything else medical, so let's just say it's general light sensitivity, you don't have any diabetic retinopathy, you don't have any cataracts, you don't have any really inflammatory dry eye that can cause light sensitivity. If you need vision correction, you need glasses, make sure that you get the anti-glare coating because that will help with the light sensitivity, and sometimes even have the anti-glare now that will help with the blue light that we get from the screens that we're staring at all day long these days because that's what we do. But oftentimes, first, number one, make sure you get your eyes checked and rule out any medical cause. And then after that, make sure that you get a good pair of glasses with that anti-glare coating.
And Casey's got a question right now. Did the blue lighting blocking lenses actually help? Casey, from personal experience, I only have readers and they have that blue light on them. They do help. My eyes get tired from staring at the screens. I find that they do help.
They do. And there are studies that confirm that if you're exposed to high energy blue light, which is what we get from our screens before bedtime, it's going to take you longer to fall asleep and it's going to take you longer to reach REM sleep, that deep sleep that's really refreshing. So especially if you're going to be on a screen close to bedtime, then it's even more important to have that blue light to help with your sleep. But even during the day, for all the hours that everybody's pulling, we've had a lot of success with the blue light to help with that eye strain and that fatigue.
Which reminds me of my story at home. I've been trying to tell my kids that don't use technology after 8 p.m. or so forth. And based on the age of my kids, you can tell how successful I've been. Not successful. So it definitely is important to not have excessive screen exposure 1 or 2 hours before. I'm a big fan of that as well.
Yes.
This next question from Brad, I think, is a great segue in what we were going to go into next, which looks like he's got a 13-year-old daughter who has type 1 for 1 year. Outside of tight glucose, what are other things that you can do to preserve eye function, or how can we prevent things from happening?
No, that's a great question, Brad. And especially with your daughter that young, I'm sure as a father, you're doing anything you possibly can to make sure that she's well taken care of. And number one, far and away, is that tight control, like you said. For every 10% you can reduce your A1C, it reduces the risk of the diabetic eye disease by 40%. Okay, so what that means is if you have an A1C of 8 and you get it down to 10%, which would be down to 7.2, that change would reduce the risk of eye disease by 40%, which is big. The other part of it that young, make sure she's getting her eyes checked every year, because that way, if we do start to see the early changes, what we run into a lot of times in clinic is we'll have a patient where, the control is always fluctuating a little bit, so 1 year they come in at 6.9, the next year it's 7.4, and it's kind of just, we're okay, but it's not great. And if we see just the very earliest signs of the diabetic eye problems, that, in a lot of times, it kind of makes it more real for the patient, and quite honestly, it becomes a big motivator to really tightening up that control and getting more consistent. But we want to know that early because it's very controllable and it's very treatable if it needs to be, rather than not getting the eyes checked for many years and then seeing the big changes that unfortunately sometimes we can't necessarily help, or it needs surgical treatment in that case.
So for that annual exam, and I'll let you two doctors duke it out. Is there a difference between dilated versus undilated?
I would say absolutely. And this goes along with the American Diabetic Association guidelines, the American Optometrist Association guidelines, everything else. With patients with diabetes, we need to have a dilated eye exam every year. That's the standard of care. Now, there are also very sophisticated retinal cameras or eye imagers that capture a very high resolution picture of the retina, and we can blow it up to 1,000 times magnification and really see the difference. So in our clinic, what we do for patients with diabetes is every year we dilate the eyes and we take that image. So we look at the image, but then we also look directly in the eye with our tools to look both ways. And that's been pretty well studied that is the most effective way to do the diabetic eye exam, because if we don't have that retinal image, I'm not perfect, I'm going to miss things. And if we only have that retinal image, it's not perfect either. And so there are times where I can catch things that it doesn't. So we really try to get both of those every single year.
So I would totally support that. I'm not going to duke that out, Jamie. Yes, annual eye exam. There's one thing I do want to mention that's pertinent to Brad. So when is eye exam recommended? Every year for type 2 diabetes. For type 1, because they're diagnosed pretty acutely, the chances are really low that they had diabetes for a while. It's recommended after 5 years of diagnosis. So something to keep in mind. Changes of diabetes are silent. They happen over years. So in type 1, when we know clearly that they were diagnosed, like right now, the recommendation is you can wait for a few years before getting the eye exam. So that's the only point I'll differ with Dr. Heisman on.
Let me do one additional poll. I want to hear from the audience real quick. When was their last visit to the eye doctor? So let us know. Are you within what Dr. Heisman is telling us? Are you within that last year, or are you not? Let us know. And let's see, if you're in the category of C or D, could be a chance for you guys to go actually meet with Dr. Heisman out at Elite Eye Care. They've got some great opportunities to be seen out there. So we can offer that on website, and so you guys can sign up and work with him directly.
We're getting a lot of B's and C's. Mine is a D.
Your patients are the best, so I knew that it would be all B's and C's.
Yeah, this is good.
And this is one note: when we do see patients with diabetes in the clinic, we always make sure that we send a report back to either their primary care provider, their endocrinologist, or Dr. Vargas' office, so they know, whoever's taking care of the diabetes knows that they got their eyes examined and they know what the status of their eye health is. We're very diligent on making sure that we communicate every single year.
This is great. So question for you, Dr. Heisman. What is best for dry eyes?
This is a wonderful question, and we could probably do 6 more of these chats to go through the dry eye conversation. So to kind of make it short and simple, number one, there's 3 ways to do it. Number one is to try to treat the symptoms. And treating the symptoms is artificial tears, re-wetting drops, things like that are pretty common. A lot of those products are over the counter, and some are better than others. You know, you're going to have some that are a little bit thicker, a little more viscous, probably going to get a little bit better relief. You're going to have some that are a little bit more watery. You're not necessarily going to get very long-lasting relief from symptoms with those. Then we can step it up to medical treatment, and there are prescription dry eye drops that, when those are appropriate, oftentimes those will help a lot more with the dry eye symptoms. And then even the next step is we can treat it medically, and there are in-office procedures, there are surgical procedures, there's non-surgical procedures for dry eye. But much like diabetes, we can't just treat dry eye once and cure it. It's always going to be, we manage it. There's going to be different ways to management, and each patient is going to be a little bit different in terms of what the most appropriate treatment is. But it is a chronic condition. There are millions of Americans who suffer from it. There is a lot that we can do. So the bottom line is, if you do have dry eyes and what you're doing isn't helping, there is more that can be done.
Jamie, I remember when we were talking about today's, there was another question you had. Uh,
Yes,
yes.
I was improvising, Dr. B.
And that's fine. That's fine.
Um, there is, and we already partially asked it, but the audience member asked, let me get it out. What guidelines can I follow to reduce my glucose levels on my own? Is there a high number that I can watch for? And is there a support group there that can help me answer my questions?
All right, that could be another conversation altogether, but I'll briefly take each one of them. So the guidelines you can follow. I mean, a good diabetes management program has four main pillars. Good nutrition, good activity, checking your sugars, and taking your medications. So having that close-knit relationship with your diabetes care team, your physician or provider, and a diabetes educator is key. And then taking your medications regularly. So it's something that you want to design with your healthcare team. In terms of numbers or targets of sugars, I've tried to say it's very simple: 80 to 120 before meals, up to 160 any other time of the day. That's a simplification from my side. There's one easy way to remember as well. If I try and share my screen, one thing I'll say is, in terms of remembering your target, you can go to my Eye-owa Diabetes portal, which is available to all Iowans for free, and where you log your sugars, but you can also set your own targets. The basic targets are what the American Diabetes Association says, and then you can change it if you want in a consultation with your healthcare team. And in terms of the last thing I would say, in terms of support group, I think the biggest one that I could recommend, if I can't find it, we'll see, is the Iowans with Diabetes Facebook group. And there's just tremendous amount of energy happening there, a lot of comments from folks and so forth. Of course, I can't find it now. There it is. And so go there and pose your questions. You guys are helping each other out, which is absolutely lovely to see. And then our team is watching this as well and answering your questions. So hopefully that answers all your questions.
And as you can see, Dr. B, we already posted our blood sugar range recommendation on Facebook. So it was on your screen and you guys can go check it out. It's something that we've made and shown you guys before. Dr. Heitzman, Carla is asking, is it true that night vision decreases as you age, and can diabetes exacerbate that problem?
Oh, that's a great question. It is common for night vision to decrease at your age. Most of that has to do with changes in the lens that sits right behind our pupil. As that lens changes and then eventually becomes cloudy, that's what a cataract is, and that's when a lot of people end up needing cataract surgery. Now, even with that, we do get natural aging changes of the retina, that it just doesn't function quite as sharply and quite as attunely. If there's any disease process of the retina, that is going to accelerate that. So if it is uncontrolled diabetes and you do start to get the diabetic retinopathy changes, that will affect that even quicker.
Carla asked us a follow-up question about optometrists versus ophthalmologists. I'll add on to it. Is there one time we should go to one versus the other, and do insurances cover them differently?
That's a great question. In terms of insurances, that's not going to be an issue one way or the other. In Iowa, and even with the federal laws, it's the same either way. Now, you just have to make sure that that particular clinic takes your insurance, because some take every insurance, some don't take every insurance. Now, in terms of optometrists and ophthalmologists, I'm an optometrist, so I am trained in vision correction and vision function. So we do exams, we treat disease, we take care of glasses, contacts, medical treatment, everything else like that. An ophthalmologist is someone who is a medical doctor. They went to medical school and then specialized in eye disease and eye surgery. So if you need an eye surgery, that's definitely when you're going to see an ophthalmologist. So for us, we see many, many, many patients with diabetes in our office. And thankfully, most of those patients are doing well with their control, and they don't have any need for surgery or surgical treatment of their diabetic eye disease. But when they do, we have partnerships with great local ophthalmologists who are retina specialists, that when a surgical treatment is needed, we can refer to those patients and work with that doctor to get the surgical treatment that's needed. And then usually they'll come back to our care to monitor for any further changes. So hopefully that helps with the explanation.
Yeah. And I think the last question from the audience that I'm seeing is from Sharon, and she wore contacts most of her childhood. She had cataract surgery and now has to wear readers. Is there a contact that can be worn successfully for close-up vision?
That's a great question. We are very fortunate, especially in the last probably like 5 to 10 years, we've gotten a lot of really good bifocal contact lenses, which sounds a little bit different, but the technology and the engineering has progressed tremendously over the past several years. And we fit a lot of bifocal contact lenses now that can reduce or eliminate the need to be carrying around the reading glasses all the time.
Cool. I didn't know that existed.
Yes.
Yeah. Last 25 years, I've been debating about contacts, so I guess now I can do it.
So
Great questions from the audience. Yeah.
we went through, the common symptoms and how to prevent them. So what is your recommendation to our audience? Like, how do they decide when do they need to seek immediate help versus when can it wait for like an annual?
That's a great question. The general rule of thumb, to keep it simple, if it's something that's a gradual change, that's not as urgent. So if you notice, it's a slow change in vision and you can't see the clock on the microwave quite as sharp and it seems like it's changing a little bit as time goes along, that's not as urgent. If it's the things that we really worry about are the sudden change. If, boy, you could see great yesterday, but now if I cover my right eye, boy, it's really cloudy right in the center, and that happened very suddenly. That's when we need to see you, if not the same day, within 24 hours to do that. And it's that sudden change, either a loss of vision, meaning it's gray and you can't see, or everything's distorted and that happens really suddenly. That's when you need to make sure that you call and get in right away.
Now, Dr. Bhargava, is there any point within diabetes that you would say, hold off, don't go see the eye doctor?
Well, I think in general, I will always say go see the eye doctor. But yes, there is a situation that I'm so glad you mentioned that. So when your sugars are fluctuating quite a bit, when they're running high, 200s and above, consistently, this leads to a change in the shape of your lens. That changes your vision. That is not the right time to get eyeglasses. So I usually tell people, I need you in control, and then go see the eye doctor. So that's one situation with consistently high blood sugars for a while. That's when you would want to wait and get prescriptions done. You could still get your retina eye exam and so forth, but not eyeglasses, because if you do, then in a few months when we fix your sugars, well, you'll be looking for another pair of glasses.
Perfect. I think we've answered all of the questions. So I think we can start to go through what your guys' top takeaways for today are.
Dr. Heisman, you want to go first, or I always have things to say and I learned something.
Go ahead and I will follow.
Okay, so first of all, well-controlled diabetes is the cause of nothing, right? That's one point I want to emphasize. The second, the diabetes is still the leading cause of blindness in adult age groups, working class age groups. So that's really important to address. Those annual dilated eye exams are the key. The one new thing I learned today, which I really like, and it's so easy to teach, thanks to Dr. Heisman, is gradual changes, you can go gradually. Sudden changes, you need to go immediately. That is a great, very simple message that my key take home today is.
I think that's perfect. I think that's spot on for me as well. And then the other thing that I think I knew, but I definitely learned, is your patients are fantastic, because it looks like all of them have had their eye exam within the last 12 months. So keep up the good work.
Excellent.
And
go ahead, Jamie.
I was just going to say, now I get to have the pleasure of talking about what we're going to be doing next week. First off, this was a great session. Dr. Heisman, thank you so much. The information was very well presented, and I think our audience thought the same thing because they were speaking up and asking you more and more questions.
Excellent. Thanks for the opportunity. I really appreciate it.
Yeah.
Thank you, Dr. Heisman. Very much appreciated. Yeah.
Our next session in 2 weeks is going to be bringing back our goal setting. So at the beginning of the year, we had you guys set goals. And even if you didn't participate in that, I want you to participate because most people are setting goals at the beginning of the year with New Year's resolutions. So we're going to go ready, set, goal. How is your 2021 going? And really kind of go through a reassessment of your progress to make sure that you're getting your annual goals met. So excited to bring that concept back and to help hold each other accountable in this group.
Yes, now I remember my goal. Okay, I'll start working on it again. But yes, I think we have to do it together. So holding each other accountable is great. I'm looking forward to the session. Everybody, thank you so much for joining. Please keep joining us. Please spread the word in this fight against diabetes. Let's work together. Let's change diabetes together. Thank you.